Anuradha Agarwal Monga, and I work as a technical expert at Share India. With us, we have Dr. Upasna Agarwal. We are really fortunate to have you, ma'am. Dr. Upasna is the head of the Department Internal Medicine and in charge ICTC and ART Center at the National Institute of TB and Respiratory Diseases at New Delhi. She'll be the faculty for today's session. And topic of today's session is TB presenting as abdominal TB and PLHIV. Case will be presented by Dr. Priti Agarwal, SMO, Pandit Deendayal Upadhyay Hospital, Varanasi, Uttar Pradesh. Ma'am, may we have your case presentation? We are pulling up the case on the screen. Yes, ma'am, can you see the case?
Yeah.
Yes, ma'am, please go ahead.
Good afternoon, everyone. Thank you, e-NISCHIT team, for inviting me to present such important, interesting case. A young male HIV positive patient, about 30 years of age, registered in Pandit Deendayal ART Center on 15 May 2021. He presented with off and on fever, mild pain in abdomen, off and on diarrhea for 2 to 3 months. On 4S scanning found to be 4S positive. After registration, baseline investigation was done in which XHS was found to be within normal limit. CV not done from gargled out fluids in which MTB not detected. Ultrasonography was done in which sonologists reported edematous bowel loop, mild hepatosplenomegaly, no mesenteric and para-aortic lymphadenopathy. CD4 count at the baseline was 27 cells per microliter done on 15 May 2021. CBC, LFT, RFT was within normal limit. VDRL non-reactive. Then ART started on 18 May 2021 with TLD. Adherence was good, more than 95%. Initially, patient condition improves. After 1.5 months of start of ART, patient came to us with severe pain in abdomen and severe diarrhea for 8 to 10 days, for which repeat ultrasonography abdomen and CD4 count was advised. On 6 July, CD4 count was done, which was 285 cells per microliter. That shows an increase in CD4 count. It means more than 10 times within 1.5 to 2 months in a short span of time. Ultrasonography abdomen, sonologist reported para-aortic and retroperitoneal lymphadenopathy with nodes more than 3 millimeter in size. Edematous bowel loop, mesenteric thickness was more than 15 millimeter. These findings pointed to abdominal TB, for which CAT1 ATT was started, by which patient clinically improves. This unusual increase in CD4 count, more than 10 times from the baseline CD4 within such a short period of time, 1.5 to 2 months, along with ultrasonography findings, made us to arrive at the diagnosis of HIV abdominal TB unmasking iris.
Thank you so much, Dr. Priti.
Would you like to share some the investigations? The X-ray, I think you had an X-ray.
Yes.
Let's show that.
This was within normal limit.
It is there with us. We'll just put it on the screen.
Let us just share the investigation because you have so nicely worked it up with the audience. So as you can see, the X-ray is normal.
So I'll summarize the case. It's a 30-year-old male. He weighs 35 kgs. He registered at the ART center in May 2021. When he registered, his baseline CD4 count was 27. CBNAT was not detected and X-ray was within normal limits. Initial ultrasound had hepatosplenomegaly and edematous bowel loop, but no lymphadenopathy. Patient was initiated on ART. Then adherence was 95% and the ART was TLD. Patient's condition worsened and he developed abdominal pain and diarrhea. And in 2 months, that is July 2021, the CD4 rises to 285. Repeat ultrasound was done and it showed para-aortic lymphadenopathy greater than 3 millimeters. First line ATT was started in July 2021 and patient got relief. CD4 counts, subsequent ones were 241 November 2021 and May 2022 it was 199. Now the queries presented by Dr. Priti are, What is the guidance when abdominal symptoms are there and ultrasound reports are inconclusive? Repeat ultrasounds are not always possible. And are there any standard treatment guidelines in case of TB, HIV, and masking iris? What are the precautions to be taken regarding TB in HIV patients? So, Dr. Priti, if I can know from you if whether the summarization was correct. If I have missed anything, you can please add.
No, no, ma'am.
It's fine.
Yeah.
Do you have any queries for Dr.
So, I think it's a very nicely worked up case, and I think a very, very important issue of TB iris has been brought to the forum after a very long time. But then we will definitely like to ask the house if they have any questions or any comments before we go on with the didactic.
I want to say one thing. When we are starting ART in a low CD4 count, then we have to think in mind about the case of iris. It may be possible as in this case. So then if we needed a repeat of ultrasound, then we should do repeat ultrasound.
Yeah, thanks. That's a very good input actually. So if there is, can we pull down the poll? Is the poll done?
Yes, yes, ma'am.
Yeah.
Anybody from the audience is having any question regarding the case? Any queries?
Yeah. So let's move on to the didactic. Can I request you to share the screen and the didactic?
So I request Upasna ma'am to kindly take the session. Rakesh, please pull up the slides.
So good afternoon, everyone, and welcome to this 93rd session of e-NISCHIT. And today, Dr. Priti from from Pandit DDO Hospital, Banaras, has brought a very, very interesting case for us. And today we will be actually discussing TB iris presenting as abdominal TB in a person living with HIV. Now, this particular problem has two aspects. One is of TB iris and the other is of abdominal TB. And both are slightly difficult concepts because they are diagnostic dilemmas and management dilemmas, both of them. So we will tackle the subject in TB iris first, and then abdominal TB, and then where the two intersect. Then we will talk about where in this particular case. So moving to the first presentation, we have, this is basically a summary of the talk, and I think Dr. Anuradha has covered it pretty well. Sorry. So what is IRIS? So IRIS is an acronym. It stands for Immune Reconstitution Inflammatory Syndrome. And actually the name is pretty explanatory. It means that when immunity is reconstituted in a patient, then we get an inflammatory response, which is not normal. It is a syndromic problem. So it is a self-explanatory statement. And it is seen not only in HIV patients, but also in non-HIV patients, but it is very, very oftenly seen in patients with HIV. If you look at the frequency in non-HIV and HIV, the frequency is much higher in HIV patients. So some HIV patients experience a clinical deterioration when they are started on ART. So there will be a period of improvement, and then suddenly you will see that the patient has started deteriorating while on ART. Now, why does this happen? It is due to exacerbation of pre-existing infection, which could be clinical. By clinical, I mean you already know that the patient has TB. You already know that the patient has PCP, or you already know that the patient has cryptococcosis. And then when you start ART, after initial improvement, there is so much of inflammation that this already, the disease or the infection that we already knew about worsens. Or you might start ART in a patient in which there is no overt infection. If there is an infection, it is subclinical, and it is not able to pick up subclinical infections by our routine clinical methods and tests. And then when you start ART, because of the exaggerated immune recovery, those subclinical infections start manifesting. So this is basically the two ways in which iris presents. And it is basically due to an improving immune system interacting with previously known or unknown pathogens or antigens. So thank you very much, Dr. Priti, for this slide and information. If you look at the etiology of iris, the thing that we just need to know in this particular session is that it can be it is of course infectious. but it can be non-infectious also. I will not go into the details because iris itself is uncommon, and then having a non-infectious etiology is even more uncommon. And out of the infectious etiologies, obviously Mycobacterium tuberculosis is the list topper. So MTB causes the maximum numbers of iris in patients with HIV. Then if we have to consider, there is cytomegalovirus. We have very often seen blindness in patients who are started on ART because of CMV iris. Cryptococcosis neoformans is also common. Sometimes patients develop cryptococcal meningitis after starting ART. And Pneumocystis jirovecii pneumonia is also a relatively less presentation as iris. Usually it is a overt presentation that we see, or it is a misdiagnosis. But these are the 4 infections which are very common. In India, we do not see much of Mycobacterium avium complex iris, though it is very common in the West. Now, after we have said that tuberculosis is the most common cause of iris in India, there is in people living with HIV in countries like India, which are high burden TB countries, so comes the term tuberculosis associated iris. And today our case is of TB associated iris. TB is the most common infection seen to be associated with iris, hence the special name TB iris. What happens in this is a patient who is improving on TB treatment suddenly starts deteriorating after an initial improvement. There is worsening of the affected site, like there is a site we know which is already affected, so either that gets worsened or suddenly new sites start appearing. And the incidence is different in different studies. Some people report an incidence of 7% and some even report an incidence of 43%. But in our experience, about 10 to 12% of people who have HIV TB and with some unmasking thrown in, about 10 to 12% of people with HIV TB get iris. It is an important early complication in co-infected patients on dual therapy. And we have to understand that the most common presentation is that it will occur within 3 months starting ART. Why I am saying usually and not always, because there are some reports of iris in the literature which have been reported and accepted to be iris even 9 months after starting ART. But if you would look at a clinical definition, because we do not have tests for it, we do not have ways how to measure fall in viral load. So clinically, we should say that it falls within 3 months of starting ART. And most of the patients develop symptoms within the first 2 to 6 months. And we have also seen iris as early as 5 days. And once you get iris, usually the patient stays sick for about 2 months. Now, what are the types of TB iris? As I have already talked about just now, there are 2 kinds of presentations that can happen. One is a case of HIV, who is also a known case of TB, right? So this patient is a known case of TB already on ATT. After waiting the appropriate duration of about 2 weeks, 10 weeks to 2 weeks, 10 days to 2 weeks, you start ART in this patient as per guideline. Now, initially the patient is seen to be improving. And then suddenly 2 to 6 weeks later, after starting ART, you see that the patient has started worsening. So this is paradoxical clinical deterioration. So this kind of TB iris is called paradoxical TB iris. But then there can be another situation also. In another situation, you have a HIV case. The patient was 4S negative. There was no evidence of TB, but the patient had subclinical or latent TB somewhere in his body, which was not manifesting. Now you started the patient on ART. Once the ART starts building the immunity of the patient, a silent or subclinical TB that was lying dormant becomes active. And you get an active TB in a patient who earlier you did not know that he had TB, and it presents with severe symptoms. So this is known as unmasking TB iris. And what could be the causes? See, there are some slides here, but basically I will not follow the slides that much. What basically I'm trying to say here is that how do we get iris? Well, there are some factors important for it. Number 1, there should be presence of the antigen in the body. Now, if you get TB, you cannot get TB iris without there being TB in your body. So the patient has to have TB in her in some way. Either it is active or it is subclinical. So the first prerequisite for getting TB iris is that you have the antigen in the body of the patient. Second is that there is a good restoration of immune responses with ART. You give the patient ART, and then he has a good he has a very good recovery. So what happens, the degree of immune restoration is higher in these patients than is expected in a regular HIV patient. There are two things that happen in this. One is the rate of immune recovery is very high. So if suppose the CD4 or the immunity was supposed to increase over probably 6 weeks, the same immunity is increasing over 1 to 2 weeks. And then the patient is having pro-inflammation all throughout his body because of this intense recovery of immunity, and that is showing us inflammatory sites. The other thing that is, one as I just said, is the rate of recovery is faster in patients who develop iris. The other thing that we have to remember is there is a dysregulation. This is not a normal immunity. This is something known as an immune pathology. What happens, we all know that once we start giving ART, the CD4 of the patient starts rising. But we have to understand that in the first month or 6 weeks, this rise in CD4 that we see is not a real CD4 rise. Actually, the CD4 cells, the memory CD4 cells, which were already present in the lymph nodes of the patient, they start getting circulated into the blood. So instead of having naive CD4 cells, we have recirculation of memory CD4 cells from lymph nodes into the blood. And if you will have existing or old CD4 cells which would circulate into the blood, what will happen? All these CD4 cells would have memories for past infections in the body. So what happens? Suddenly there is a rush of these memory CD4 cells in the blood, and these memory CD4 cells then start overproducing cytokines which are against a particular infection, so that whatever dormant signs of infection were there, they start reacting and they start clearing up. So this is basically the thing. One is there should be presence of the antigen. Second is there is a rapid restoration of immunity. And third is this immunity is exuberant. It is an immune pathology. Some people also say that there could be a genetic susceptibility to it, but that is still in the realm of research. So when does this entire pathogenesis set up? What are the risk factors? In which patients do we see that? So the usual risk factors that we would see in a review of literature would be a low baseline CD4 T cell count, like in our patient, which Dr. Priti presented. Somebody who is, there is some evidence to say that males get more iris than females. If the patient has disseminated or extrapulmonary TB, then it is seen that patient gets more iris. If there is a shorter interval between anti-TB and ART initiation, then the incidence of paradoxical iris is seen to be more. There is a decision analysis which was published by Price P and Murdoch DM, and we also like in 2006. This is an old review that we did, in which a decision analysis was seen, and it was seen that deferring ART until two months of ATT could possibly bring down iris, but we do not want to defer it because it will increase the mortality. So we are willing to take the risk of iris, but not willing to take the risk of patient dying due to HIV-TB combined infection. So all available data would favor that despite the risk of TB iris, we will initiate ART early, within 2 weeks to 2 months of TB diagnosis. How does TB iris present? It presents as worsening of the existing TB lesion, involvement of a new site, presentation of a new TB, like in unmasking TB, like in this particular case. And the manifestations are diverse. Like when we see TB iris in a non-HIV patient, it is usually a mild pleural effusion that we will see on treatment, or a small swelling of the lymph node, which we can see in an HIV negative. But in HIV positive TB iris, it's a whole another thing. There will be very exuberant responses. There will be diverse manifestations, like there will be worsening of pulmonary infiltrations. Effusions will be painful. There will be increased or new lymphadenopathy. Cutaneous lesions can be there. Splenic microabscess can be there. Fever can get prolonged. Cough can worsen. And the most deadly of them all is the CNS TB iris, in which you get a patient presenting with altered sensorium, or increased neck rigidity, or a tuberculoma which wasn't there, which wasn't giving any symptoms. And TB iris CNS also is seen to have a poor outcome. So these are some X-rays that I'm sharing of our patients who developed iris over the years. So this is the X-ray of a 38-year-old male in our hospital. So the parenchymal lesion was in the left lung and there was some left pleural effusion. The patient was started on ATT, and 6 weeks after starting ATT, the patient was well. This was the X-ray at which we started the patient on ART. Now, after starting ART, 6 weeks of ART, there was exacerbation of clinical symptoms. He came back to us saying, having hectic fever. There was uncontrolled high-grade fever, cough, shortness of breath. And when we did an X-ray, this was the X-ray of the patient. So the pulmonary infiltrates had increased so much, and there were some new pulmonary infiltrates also. If you will see the left patch that was there when we started ART, it has definitely increased. And there's a new patch in the left apex also. Now these X-rays on the top, if you would see this X-ray, which you can see on the left hand, that is of a patient who had some mediastinal lymphadenopathy and there was central necrosis, and he was CT proven. This case was a CT proven mediastinal PV case, lymphadenopathy case. Then we started him on ART. 2 weeks later, he developed this new pleural effusion, which you can see in the right lung. And also there is widening of the mediastinum because the mediastinal lymph node increased. Now, if you will see the picture which is given below the X-ray, this is not our picture, this is taken from a textbook. Initially, the patient presented with 2 lymph nodes of the cervical chain. They were enlarged, they were red. After giving ATT, they improved. If you can see in the picture on the right, their cervical lymph nodes have improved. But after ART starting, a lymph node in the axilla has developed, which wasn't there earlier. Now, this again is one of our patients. He was diagnosed as tuberculoma based on the headaches. He was started on ATT. And then once ART was started, you can see what after he started having left hemiparesis. Slowly, he started worsening, his neurological complaints started worsening. So we got a repeat CT scan done. And in the repeat CT, you can see how that localized tuberculoma, there's a new patch in the frontal region, frontoparietal region, and there is so much of liquefaction in the tuberculoma. So we can see severe manifestations also with TB iris, which can be of concern, like a tracheal compression. We have seen a patient with bullous neck. There were cervical lymph nodes. There were few cervical lymph nodes. After giving ART, it became a bullous neck. There was increase in size of the existing ones. New cervical lymph nodes came up, and the patient actually developed stridor due to tracheal compression. There can be ileal perforation. There can be acute respiratory distress. There can be meningitis, and deaths have been reported with CNS, iris, and low CD4 counts. Because the disease per se is advanced, and then the iris complicates the picture. Now, this is one case of unmasking TB iris. This is very similar to the case of Dr. Priti. This is one of our patients. Just a minute. So in our center, like in Dr. Priti's center, we do an ultrasound for all patients who come to us on HIV because it is free, it is easily done, and we have established a baseline in our center to do an ultrasound, a pre-ART screening ultrasound, we call it. And this is a tertiary institute. So if you will look at the first picture on the left, this is the pre-ART ultrasound. Now in this pre-ART ultrasound, the only thing that we can see is the minimal ascites. It is not sufficient in a 4S negative person to form the diagnosis of abdominal TB. So this patient was not diagnosed with TB, but this ultrasound was recorded in the file and the patient was started on ART. Now 3 weeks after ART, the patient came with frank subacute intestinal obstruction. There was distension of abdomen. The patient could just pass platters, could not pass stool, and there was recurrent vomiting. And she had a painful abdominal condition, and all signs and symptoms of subacute intestinal obstruction were there. We repeated the ultrasound, and this time, if you will see, there was a SOL in the spleen. If you will look at the left-sided ultrasound picture on the bottom. So there is a splenic abscess, plus there are marked retroperitoneal lymph nodes with central necrosis. So in this case also, an abdominal tuberculosis were diagnosed as unmasking of TB. Now, why am I showing this picture again? You have somebody who comes like this, who's already sick, and after starting ART, the extra becomes like this. Then it's a big issue. It's a big issue for the patient. They came to you to get better, and they are not getting better. So what can it be? Is the patient not taking drugs? Is it possible that the patient took drugs for some time and then he stopped taking drugs, and that is why he's becoming worse? That should be the first thing that you should check with a picture like this. Or is it a misdiagnosis? Is it possible that there was TB earlier, we missed it? Or this wasn't TB at all? This was cryptococcosis. This was a staph infection. Have we missed something? Or if it was TB, is it drug-resistant TB? Have we been treating it wrong all this time? And now finally it has caught up. The wrong diagnosis has caught up. The other thing that would come to you would be a drug side effect. Suppose a patient only comes to you with increase in fever and increase in cough, or dizziness, as in the case of TBM, you might start thinking probably it's a drug side effect. Or is it an alternate diagnosis? So this is the diagnostic dilemma you get when a patient who was doing well starts deteriorating on ART. So unfortunately, there is no specific test to diagnose or confirm the diagnosis of TB-IRIS. It is a diagnosis of exclusion. Once you have ruled out non-adherence, you have ruled out drug-resistant TB, you have taken a good history to see if there is any relation to drug side effect. Once you have done a quick check for other opportunistic infections, you say, okay, so this patient is IRIS. So one, it is a diagnosis, it is a clinical diagnosis of exclusion. Secondly, there will be a temporal association with ART. There will be a very, very clear-cut time association that, okay, the patient was doing well, we started ART, the patient was still well, and 1 week, 2 weeks, 3 weeks later, the patient gets bad. And the third important thing would be, there will be clinical worsening in the face of improving immune function. So as Dr. Priti just now told her that her patient had a very good CD4 despite of clinical deterioration, which shows that the immunity is good. It's actually extra good. It's extra good. So immunity is extra good, but the patient is deteriorating. So this is a very, very essential part. But one word of caution here is sometimes IRIS occurs so soon, like 5 days, 6 days, 1 week, when you still are not able to see a rise in CD4 count, because CD4 count rise takes some time. Even there is a minimum time. So in the West, what they do is, they do a viral load at the beginning of treatment for all patients. So what will be the first sign? It will be a rapid fall in viral load of more than 1 log. If you are able to demonstrate a rapid fall in viral load at the time of worsening symptoms, then also you can say that, okay, there is an improving immune function, but my patient is worsening. But by and large, in our clinical setting, you can of course order a CD4 count, but sometimes you might not see a rise in CD4 count because it is too early, and still the patient might have TB-IRIS. So when you don't have a test, it's a diagnosis of exclusion, and viral load has its limitation, CD4 has its limitation. The best option to diagnose TB-IRIS for us would be the INCHI definitions. INCHI is actually the international network for studying IRIS in HIV positive patients, and this relies on case definitions, and it incorporates some clinical data, which is some laboratory data, which is not essential. So this is by way a standardized way of the INCHI definitions are a standardized way of diagnosing TB-IRIS. So they again have divided IRIS into 2 versions. One is the paradoxical, one is the unmasking. For paradoxical, for diagnosing a patient of HIV, to have paradoxical TB-IRIS, what should be the 3 components are? Number 1, there should be a diagnosis of TB. And this TB diagnosis should be before starting ART. And there should be initial response to ATT in the patient. It's not as if that he was failing from the first instance. So there should be an initial response to ATT. Then you can have any one of these major criteria. Now, what is the major criteria? You see a new or enlarging lymph node, cold abscess, or a focal tissue. There are new or worsening radiological features, new or worsening signs and symptoms of CNS TB, or new or worsening effusions like pleural effusion, ascites, or pericardial effusion. If you do not have any of this major criteria, but you already have a patient of TB who did well, then there are certain minor criteria also. If you can get two of those minor criteria, then also you are by and large having a confirmed case of TB-IRS according to this INCHI definition. Now, the minor criteria is that you have new onset fever and other and 4S symptoms or worsening of these 4S symptoms. You have new respiratory symptoms or worsening of existing respiratory symptoms and a new or worsening abdominal pain. Okay. And an alternate explanation can, and the third part is there is no alternate explanation. So once again, it comes back to the fact that it is a diagnosis of exclusion. Please ensure that the patient is taking drugs. Please ensure it is not a drug side effect. Please just do a quick check for other opportunistic infections and just have a look if it is drug resistant TB. So this was about paradoxical TB. You diagnose it on the basis of the fact that the patient already has TB, diagnosed TB on ATT, did well on ATT, then he started having worsening of symptoms or worsening of signs, and then it is ruled out that it can be caused by any other reason. Now, what about unmasking TB? In unmasking TB, the INCHI guideline says that the patient is not receiving TB treatment when ART started, but when he presents with active TB, within 3 months of starting ART, as was the case in Dr. Priti Agarwal's case. And either the clinical manifestations are very heightened, like it was in her case, the patient came with severe pain. There was a heightened clinical manifestation, and once established on ATT, the clinical course, and once established on ATT, the patient improves with ATT, or the patient has a very protracted course. But in Priti's case, the patient did very well on ATT. So Priti's case totally fits the INCHI definition of unmasking TB. Now, I'm just taking an opportunity to talk about some publications that we had in TB. These are old publications. We did this in Age Research and Therapy. So what we did was it was a prospective study. And then we looked at their clinical parameters, and though they say that young age, male sex, less CD4 count, all these have an effect on who gets IRIS and who doesn't get IRIS. In our study group, they were similar in age, like patients with IRIS and patients without IRIS, HIV TB cases were similar in age, baseline CD4, type of TB, duration of ATT before ART, and CD4 recovery. So the only thing that I want to say there is these are factors which are most commonly associated, but they don't have to be there. It's not a sacrosanct thing that the patient has to be young, that the patient has to have disseminated TB, that the patient has to have low baseline CD4. It is commoner, but not essential. Then we also cultured all our patients who got TB IRIS, and we saw that isolation of MTB prior to ART was twice as common in patients who later developed IRIS, because we recruited them when they were still HIV TB cases, and then we followed the cohort, and then we see who got TB IRIS. So we found there were more culture and sputum positive cases in the IRIS group, thereby meaning possibly that the level of antigen or the level of infection might be higher in patients who get IRIS or the bacillary load. Then we also did certain chemokines and cytokines, and we found that TB IRIS patients have a lower level of chemokines right at the start. Even when they start ART, they have less chemokines, which can control bacteria. And once they are started on ART, they have higher pro-inflammatory cytokines. Again, coming to the fact that this is an immune pathology. So this was just a little work that we wanted to share with you. We also tried to look for a genetic carrier. So in Indian patients, we did not find any genetic predisposition, though we found in Cambodian patients, they had a specific single nucleotide polymorphism. So this was about our experience with IRIS, about this. This was a multi-center and a multinational study with Australia that we had done at our center way back in 2010, I think we did it. So after sharing this data with you, I would like to talk about how do you manage TB IRIS? Well, most cases are mild to moderate. They resolve without any intervention. Symptomatic treatment should be the first prescription. Like you give them some painkiller. If there is a small pleural effusion with pleural pain, give them a painkiller. Give them painkiller SOS or give them a painkiller round the clock for 3 to 4 days, and most likely they will subside. You do not need to change therapy. You can continue ART, you can continue ATT as before. However, if it's the rare circumstance where it is a serious reaction of tracheal compression, massive adenopathy, respiratory difficulty, meningeal disease, pericardial disease, then please do start prednisolone. You would have to give steroids at the level of 1 to 2 milligram per kg for 2 to 6 weeks to tide over this immune pathology. And rarely in cases of CNS TB, we have also had to discontinue ART. Please understand that is very, very, very rare to discontinue ART. Usually you can manage ATT, ART steroids, ATT, ART symptomatic treatment. Rarely the condition is so bad that you have to stop ART. And we have had to do it in 2 CNS IRS cases we were just unable to turn around the disease without stopping ART in these cases. So that's a rare circumstance. So this was about TB IRS. Does the house have any question about TB IRS till now? If there are any questions on TB IRS, I would be happy to answer them now before I move on to abdominal TB, which is the second diagnostic dilemma in this case. It's very rare that we see a case with 2 diagnostic problems. Any question? No? So, okay. So now we go on to abdominal TB in a person with HIV. So abdominal TB refers to TB disease of any organ in the abdominal cavity, including the gut and the peritoneum. It is a common site of EPTB and PLHIV in people with HIV positive cases who come from high TB burden countries. And in our hospital, it is the commonest site of EPTB. Like the first commonest site is PTB, and the second is out of EPTB, it is abdominal TB. So it is such a common thing. And it can present, abdominal TB might be the only site of active TB, or it may be seen alongside other affected sites. Okay, and it could be seen in 20 to 30% of TB cases within PLHIV. We have to understand TB of abdomen has non-specific symptoms. If there is no accompanying PTB, like if there's no pulmonary TB in this patient, the patient will only present to you as 4S positive. He will say, I have fever. He will say, I have weight loss. Or he will say, I have night sweats. Occasionally cough also. So now you have a 4S positive person, you send him for an X-ray, you send him for a CBNAT. X-ray is also negative. CBNAT is also negative. Now what? Do we ignore the 4S? No. You have to understand that there is an entity of extrapulmonary TB, which is also picked up by the 4S symptom complex. 4S symptom complex is not only for EPTB, only for pulmonary TB, it is also for EPTB. So now you will go trying to find where is the site of the EPTB. So what should you do? A detailed examination of the lymph nodes of the neck, axilla, and groin. Number 1. It could be a peripheral lymph node TB. Number 2, get an ultrasound of the abdomen and also ask for additional signs and symptoms. Look for neck rigidity, okay? Look for any bone or joint or back spinal deformity or any pain in any bone, joint, or spine. So this is how you will go ahead in a patient who is 4S positive, but X-ray is normal and CBNAT is negative. And more often than not, ultrasound abdomen is really helpful in these patients. Either it will be a peripheral lymph node or it will be an ultrasound or it will be an abdominal TB. That is the most common sequence of events in a person with EPTB, in a person with HIV. So please get an ultrasound done. Common symptoms would be fever, weight loss, night sweats with or without abdominal symptoms like pain or diarrhea. Abdominal examination may be absolutely normal, or there may be tenderness, distension, an abdominal lump, or free fluid. We should not say, okay, everything is normal in this patient, so I will not ask for further questions. Everything can be normal in only few cases. Usually they have additional symptoms. Usually they have additional physical findings. So please, in a patient who is 4S positive with a normal X-ray, do not forego a history of additional symptoms and additional examination of extrapulmonary sites. And unless specifically looked for, the diagnosis of abdominal TB can be delayed or entirely missed in cases where there is a vague symptomatology. Clinical specimens are usually not available for testing, and so a microbiological diagnosis is difficult, and we usually have a probable TB diagnosis, a clinically diagnosed TB diagnosis. It is rare to have a microbiologically confirmed TB diagnosis in people with abdominal TB. But the heartening thing here is that ultrasound abdomen is sufficient to diagnose abdominal TB. There are some typical ultrasound features for abdominal TB, which would be indicative of tubercular activity. First would be enlargement of abdominal lymph nodes. Usually we call enlargement something that is more than 1.5 centimeter. They may be matted, they may not be matted. There would usually be zones of hypoechogenicity in the center, which is caseation necrosis. There can be lymph node masses. There can be micro abscesses, which are seen as hypoechoic lesions in the spleen and liver. There can be hepatosplenomegaly. There can be bowel loop thickening. There can be ascites. So this is such a huge spectrum of findings that a permutation and combination of these findings, I would say that some findings would be sufficient solitarily to diagnose. That would be a 4S positive person with multiple enlarged abdominal lymph nodes. But if you have only splenic abscesses, the patient does not have 4S positive, is X-ray is normal, that might not be sufficient to make a diagnosis of abdominal TB. So then you have to look at other ultrasonic features. Does the patient also have ascites, even if it is minimal? Does the patient have bowel loop thickening? Are there small sub-centimetric lymph nodes which appear to be matted or which appear to be developing diseases? Are there more than one findings in the ultrasound? The patient is symptomatic or mildly symptomatic. And that is when we say, okay, so this patient is a clinically diagnosed case of abdominal TB. And I tell you, ultrasound is such a beautiful investigation for abdominal TB. There are very few cases which need to go to a CT scan. And ultrasound can by and large diagnose 98% of the cases of abdominal TB. Other investigations, if there's ascitic fluid, definitely do ascitic fluid tapping, send the protein, send the sugar, send the cytology, and if possible, send for MGIT culture. Ultrasound guided needle, if the lymph node is big enough, or it is a lymph node mass, or if it is not retroperitoneal. You could do a ileocolonoscopy, barium studies to look for bowel loop thickenings, an MR abdomen and laparoscopy, but these things are usually not present to a ART physician. And so we mostly have to rely on our symptoms, our physical examination and ultrasound, and possibly a ascitic fluid tapping. Now, what is the treatment of patients with abdominal TB? It remains the same. You will give daily treatment in the form of FDCs for 6 months, 2 months of HRZE daily, then shift over to 4 months of HRE. Treatment duration 6 months, but you have to understand that it can be extended by 3 months as per the index extrapulmonary TB guidelines at the discretion of the treating clinician, which would be you, in case of slow or inadequate response. Now, how to say it is a slow or inadequate response? You see, follow-up and monitoring of ATT in abdominal TB is a challenge because you do not have microbiological diagnosis. So what you can do clinical monitoring and an ultrasound radiological monitoring. In a clinical monitoring, every month on every visit, do look for weight gain, look for abatement of symptoms, patient becomes afebrile, is he stable, and especially do this at the end of IP and at the end of 6 months of ATT. Similarly, you can also do an ultrasound abdomen before end of treatment, that is at the end of 6 months. Please do an ultrasound abdomen to see what is the improvement in the ultrasound picture of the patient along with the clinical improvement. So with the help of a clinical and a radiological monitoring, you can monitor this patient. And if the patient has become well symptomatically and ultrasound has by and large become normal, though in a few cases, some small subcentimetric scattered lymph nodes may persist even after treatment success, they are not taken as a sign of treatment failure, then you can safely stop the patient's treatment at 6 months. But if you feel there are some symptoms persistent, or there are some persistent ultrasound findings, please extend it by another 3 months. So this is another study that we had done in a center about abdominal TB. This was 8 years data. And in this particular, And we actually had 431 cases of HIV TB, out of which 200 patients had abdominal TB. Out of these 200 patients, 113 had abdominal TB with pulmonary TB or some other site which could have been easily accessed. But in 87 patients, abdominal TB was the only site of TB. And these patients were either 4S positive or had some other symptom like diarrhea or pain abdomen. And if an ultrasound had not been done or the index of suspicion had not been high, these 87 patients could have been missed. So in a study, about 15% cases of HIV diagnosed with new abdominal TB due to a baseline ultrasound abdomen. By saying that, I'm not saying that everybody should start getting an baseline ultrasound abdomen for all cases. But as Dr. Priti said, yes, for mildly symptomatic cases, for people who are 4S positive, but X-rays are normal, and for cases where you cannot find a reason for them not improving, it would be a good idea to get an ultrasound abdomen. Weight loss, fever, cough, and diarrhea were the most common symptoms that we saw, but 50% of the patients only had constitutional symptom, and 20% did not have any symptom. Diarrhea was seen in 47% cases. So diarrhea was a symptom of abdominal TB also and of advanced HIV disease also. So sometimes if you are not able to get rid of diarrhea in a patient of HIV, then please get an ultrasound abdomen and see he might be suffering from abdominal TB. And this was the combination and the permutation of all the findings that we had in our center. There was somebody with enlarged lymph nodes, thickened bowel loops, hepatosplenomegaly. Then some with enlarged lymph nodes, thickened bowel loops, ascites. Enlarged lymph nodes, splenic abscesses, hepatosplenomegaly. Then splenic abscess, ascites. Then people with only splenic abscess and hepatomegaly. Then with thickened bowel loops and ascites. Some people with proper enlarged lymph nodes only, which were more than 1.5 millimeter, had central necrosis. 1.5 centimeter had central necrosis and were matted. We had two patients with only ascites. Then we had some patients with only thickened bowel loops and some with only splenic micro abscesses. So this is just to tell you how a patient can present with abdominal TB. An HIV infected patient can have any one of these findings or a permutation and combination of these findings in the ultrasound. And abdominal, now coming to the intersection. The last slide about the intersection of abdominal TB and TB iris, it can be either paradoxical. That is, you have a patient who already has TB and then he starts complaining of abdominal pain. You get an ultrasound done and this time you get lymph nodes in the abdomen or you get some abdominal TB finding. Or it can be unmasking, as was in today's case. They had an earlier ultrasound, also a baseline ultrasound, which showed vague findings which could not have labeled the patient as active TB. But after giving ART, the patient developed pain abdomen. When they reviewed the ultrasound, when they repeated the ultrasound, they found that this time the findings of the ultrasound were multiple, and this time the patient would be easily labeled as a clinically diagnosed abdominal TB. A baseline ultrasound का यही फायदा है. This is the use of a baseline ultrasound. If you have a baseline ultrasound in which you have ruled out abdominal TB, if the patient develops symptoms later or complaints later, you repeat an ultrasound and then you see lymph nodes, you know this is a new finding and you had not missed it at the outset. So that is actually the benefit of a baseline ultrasound. But again, I'm saying it is not to be done in all patients. We have to choose a patient category, people with low CD4 count, people who have normal X-rays but are 4S positive, or people who have abdominal symptoms. And how do you manage? Same as all iris. In case of paradoxical abdominal TB, continue ATT. In case of unmasking, start ATT immediately. If ART has not been started, then you initiate ART as soon as possible, between 2 weeks to 2 months. Give symptomatic treatment. You can give one of the antispasmodics for pain abdomen, or you can do the subacute intestinal obstruction protocol as we did in our case. We put the patient on liquid diet, we put in a Ryle's tube, and in our particular case, the patient was very, very sick, so we also gave a low dose steroid for 2 weeks. So rarely steroids. And in some CNS cases, or in some very, very severe cases where you fear perforation, then you could also temporarily withhold ART. So this is all on TB iris, abdominal TB, and abdominal TB presenting as unmasking TB iris or paradoxical TB iris. Thank you for a patient hearing.
Well, thank you so much, ma'am. Thanks for an excellent presentation and phenomenal work you've already done in this domain. Ma'am, may I ask your reflections on the diagnosis of further workup of the case? What are your key recommendations for such cases? Is there anything which could have been done in a better way in this case?
Actually, they have done it pretty well, frankly speaking, and I congratulate them for that. There was an X-ray at the baseline, there was an ultrasound at the baseline, there was a CD4 at the baseline. Then when the patient became sick, they repeated their CD4, their X-ray, and their ultrasound. And so they were able to pick up a new presentation which wasn't there earlier. And promptly they started ATT and the patient also improved, which shows that they have done it very, very well. But I would definitely ask Dr. Agarwal if she has any questions or any queries that were left unsolved.
No, ma'am.
It's clear?
Oh, no, ma'am. It's clear.
Okay, thank you. You actually did a very good job. Anybody else from the house wants to ask anything?
Any questions from the audience?
I think Dr.
I think
yes,
Dr.
sir.
Dharampal, sir, please,
Sir, Dr. Dharampal, sir, please.
please unmute, sir. You can unmute.
Your presentation is very good. I am extremely happy by your explanation. Because previously, once we have had a lecturer from one gentleman from your side only.
Okay.
For the endometriosis told on that day. About the abdomen, how the abdomen cases will be there, how the intestines are there. Like that, they explained. That was clearly remembered. But here in this case, starting is the CD4 is 27.
Yes.
Any history, family history of any person, because the age is only 37 years for the patient, young age. And any family member or any other person, or whether he has taken any treatment previously, uninterrupted treatment like that, maybe the reason. That is one point. The second is any before asking about diarrhea or abdominal pain, just you mentioned, that is also issue we have to take. Previously, so many times we mentioned. So our nurse is routinely asking what cause symptoms, whether abdominal pain, previously treatment has taken, or whether discontinued, like we are doing that. So that is one case. And regarding this one, the treatment also 6 months we told previously, 9 months like that. So there is a clear cut. But here in this case, I think the abdominal edema, first of all, they have given no lymph nodes, but there is lymph nodes. That's the invasion they found it. So there may be a previous infection may be there that indicates the patient was covered previously with tuberculosis. That is one of the indications I found. So naturally, when the treatment after starting ERT, within and that day also you mentioned and you also supported that one. The iris will come whenever the abdominal will come within 3 months, but not 3 years to 6 months. And another point is CTX also not given because below 350 we have to give CTX in the beginning, starting to prevent the pneumonitis and other things also. Maybe that may support it and that may be the one of the reasons they found. So I want about the family still will be there. Anybody was covered in the family or anybody. This is a virgin case. I think it is not a virgin case.
Sorry, there was a momentary problem with our audio. Sir, thank you very much for your inputs. I think all the points that you pointed out were very, very important. And yes, reiterating, earlier ultrasound, though it showed lymph nodes, they were just, there was a hepatomegaly, I think. There was a hepatosplenomegaly, and that's all right. It's, yeah. So they were very right in not labeling it as abdominal TB at that time. And once she became symptomatic, so symptoms become a big plus. And then secondly, appearance of new lymphadenopathy is also a big plus for diagnosis. And Dr. Dharampal, all your points are very, very well taken. Any comment or anything else from the audience? If not, then I will hand over the session to Dr. Anuradha.
And there is a feedback poll on your screen, so kindly fill in the feedback poll. While you are filling in the feedback poll, ma'am, one last question from you. We've been hearing about iris and we all have been facing this problem. Can we say that iris is partially iatrogenic?
Iris is definitely iatrogenic. Iris is only seen when you start increasing the immunity due to your drugs. So it is definitely a iatrogenic complication, but it is something that we see. It's actually a very interesting complication that you give treatment to for the patient to get better, but actually in this 10% people, the patient gets worse, 10% cases. So yes, it is definitely iatrogenic.
And ma'am, while it's crystal clear from your presentation that the treatment is always symptomatic and in severe cases we go for steroids, but however, there is always a question in mind, is there a difference in the treatment of paradoxical and unmasking?
No, because basically you treat HIV, you treat TB, you treat HIV, and if there is too much inflammation, then you give steroids. So it doesn't change whether it's paradoxical or unmasking. Yeah, the only difference would be in paradoxical, the patient would already be on ATT and ART. But in unmasking, the patient would be only on ART and you have to start ATT immediately. But that doesn't mean that you stop the ART.
Correct. Thank you so much, ma'am. Thanks a lot. So now we will come to the answers of the pre and post test poll. There were 2 questions.
I think somebody's.
Is anybody having any query though? And would anybody like to add on the diagnosis or the treatment recommendations that we have discussed? ART Bima Varam, would you like to add something? I think you are.
Madam, suppose the TB is involved the spinal cord, the spots disease, spots.
Yes, sir. Yes, sir.
Then the vertebra is completely liquefied. What we have to do?
Sir, we actually had a very interesting talk on spinal TB. We will note down your, we had it about 2-3 sessions back. Sir, we will note down your email and we will send you the link to that presentation. It was given by a very senior orthopedic surgeon who is an expert in spinal TB. So can I request Dr. Anuradha?
Madam, I had an answer. We have to take a bone from the pelvic and had to add 2 bones there, and we had to mainly attach the bone with screwing.
Sir, that is right, but that is the domain of what you are saying is that is the domain of an orthopedic or a neurosurgeon. And sir, that is one way of fixing the spine.
Yes,
Screws and bone, that is one way of fixing the spine, but there are several other ways of fixing the spine of which we are not even aware because we are not orthopedic surgeons. And if you want, we can send you that link. But there is more than one way in which you can fix a liquefied spine.
Okay.
Thank you so much for that query. And if you still have any questions related to the questions session which are left, kindly email us and we will definitely get back on them. Our email ID is e-NISCHIT@gmail.com and written recommendations for this session will be emailed shortly along with the YouTube video link. And I again request all the participants to kindly subscribe to our channel. On that channel, all the previous videos of the session that we have conducted are already present. As ma'am said, if you want to watch any of the session, you can definitely go to that channel and see it. And now coming on to the pre and post test answers, they are on your, Rakesh, can you pull up those question answers? Yes. So the first question was, which of the following is not true for TB, IRS and PLHIV? And the correct answer is option C. ART has to be stopped in all cases. No, it hasn't, it is not to be stopped. Then second question was, which of the following is not true for abdominal TB in PLHIV? The answer B is correct. PLHIV with abdominal TB are 4S negative. No, they are not 4S negative, as ma'am clearly said in one of her slides. So these are the correct answers for the 2 questions that we had. And we encourage all ART staff members to please keep submitting their case presentations for future clinics. And certificates will be issued for each case presented. And it's exactly a very great opportunity for all of you to represent your state on the national platform. With this, a big thanks to Dr. Priti for bringing such an interesting case to us, and Upasna ma'am, as always, for making the case so simple to understand and learning so enjoyable. Thank you so much, ma'am. Thanks, Dr.
Thank
Priti.
you, ma'am. Thank you, Dr. Upasna, and thank you, Dr. Anuradha.
Thank you. And thank you all for joining our session today. Ma'am, any last words?
Thank you so much.
Next session, we'll keep you updated about the dates. We have not decided the dates as yet, but then we'll keep you informed. Thank you all.